Buenos días a todos. Yo creo que ya vamos a comenzar. Doctor Sotiria.
Yes, I'm here.
Καλωσήρατε, κυρία Σωτηρία.
Ευχαριστώ.
Χρειάζεται και σας ευχαριστούμε που μας τιμάτε με την παρουσία σας. Αν μαθαίνετε την άδεια το πόλυπο της συνεδρίας μας, θα το ακούσετε στην αγγλική.
Ευχαριστώ πολύ. Yes, I agree. Συμφωνώ.
Perfect. First of all, let me welcome all our distinguished guests, all of my fellow residents, Dr. Betty Muñoz, our Chief of Teaching, Dr. Analia Pérez Balbuena from the Asociación para Evitar la Ceguera en México, all the subspecialists to be, especially Dr. Rodrigo Mateos from the Glaucoma Service. And let me introduce to you our honored guest, to this general session, Dr. Sotiria Paliura. Dr. Sotiria is native from Greece. She completed her undergrad, her graduate, and medical studies with honors and full scholarship at Yale University. She made her residency in ophthalmology at the Harvard Department of Ophthalmology, her fellowship in cornea and external eye disease in the Bascom Palmer Eye Institute. Currently, she practices in Greece, in Cyprus, and in the USA. She's a visiting professor of ophthalmology in the University of Cyprus and adjunct assistant professor of ophthalmology at Yale School of Medicine at the Bascom Palmer Eye Institute. Dr. Sotiria, thank you for your assistance, and I hope you will find this session very interesting about your case. Before everything, all the images of the case and all the information is from Dr. Sotiria's article. Now, I'm Dr. Jose Manuel Rodriguez, second year ophthalmology resident, and I led you with my colleague, Dr. Manuel Peña, from first year ophthalmology resident.
Keratitis is a corneal disease caused by fungal organisms. It's one of the most difficult forms of microbial keratitis for the ophthalmologist to diagnose and treat successfully. Fungi are ubiquitous organisms that recognize more frequently as ocular pathogens in agrarian tropical countries than in the developed world. Fungal keratitis is less common than bacterial keratitis, generally representing less than 5 to 10% of corneal infections. Fungal organisms of ophthalmic interest may be classified into 4 grades: filamentous septate, filamentous non-septate, yes, and others. Filamentous organisms are multicellular with branched hyphae. Yes, such Candida and Cryptococcus are unicellular fungi that reproduce by budding, but in tissue they might develop in love buds or real hyphae. In the worldwide, Aspergillus species are the most common fungus responsible for the fungal keratitis. And in North America, Fusarium, Aspergillus, and Candida are the most common organisms. Next. Thanks. We have the risk factors. In various ocular factors, they may predispose to the occurrence in fungal keratitis include trauma, contact lens wear, medications, and preocular surgery. Concurrent contamination with plant material presents an increased risk of fungal keratitis. Also occurs more commonly in case of previously compromised cornea of corneal scars. Some systemic disease associated with immunosuppression may increase the risk of development of fungal keratitis. These include disease as diabetes mellitus, patients with chronic developed disease who are hospitalized in intense care units, HIV positive patients, and case of leprosy. In general, the clinical features, the symptoms of fungal keratitis are less severe as compared to bacterial and viral keratitis. Fungal keratitis may be associated with certain general symptoms and things, and also specific features which may clinical point to a etiology agent. The onset of fungal keratitis is almost always insidious. Symptoms are usually non-specific, although possibly more prolonged duration, 5 to 10 days approximately. Patients generally complain to a foreign body sensation for several days with a slow onset of increasing pain and diminution of vision, especially in keratitis involves the visual axis. Then we have examples in the image. In the first, central features suggest a filamentous fungal infection, including the feathering edge or dry gray elevated infiltrate and satellite lesions. In the second image, we can see a high level of suspicion for no bacterial keratitis must be maintained at all times, especially in those areas where the incidence of fungal keratitis is relatively high. Next. On a slit lamp examination, the infiltrates appear grayish with or yellowish, while the base of the ulcer is often filled with soft, creamy, and raised exudate. The fungal ulcers have characteristic findings which include elevated areas, effective ulcers, irregular feathering margins, dry rough, the texture of satellite lesions. We have an example for aspergillus species. On the other hand, causes are less severe than non-rotational progressive keratitis, which is amenable to therapy. In this image, we can see an immune ring, endothelial plaque and posterior corneal abscess may be represented rarely. And in the second image, we can see the appearance of macroscopic brown pigmentation in fungal keratitis that may be due to the presence of the metaceous fungus. The pigmentation has been related to the alteration in the melanin metabolism, and when present indicates of more superficial infection. low virulence of the organisms, and less inflammatory reaction. In this image, in the first, we can see Fusarium solani keratitis has a more severe course of, so that deep extension and perforation may occur in few weeks. And in the second, we can see the famous acollar bottom, that is a configuration typical in keratitis caused by yeast, which is often associated with a small ulceration and expanding the stress stromal infiltrate. The stromal keratitis caused by albicans, related fungal resembling bacterial keratitis with overlying epithelial defects and more discrete infiltrate and slow progression. So ulcers frequently occur in eyes with persistent corneal disease and in areas of exposure typical and the junction of superior two-thirds and inferior one-third of the cornea. To the diagnostic requires laboratory confirmation. Scrapings for stain and culture should be obtained as described for bacterial keratitis. If fungal infection is suspected after LASIK, the frag must be elevated to obtain samples. The smears diagnostic is primarily made by Gensia or ink potassium hydroxide stains. The fungal elements are also visible in gram stain. In the laboratory, diagnostic of fungal keratitis primarily includes the direct microscopic fungal cultures, and newer diagnostic modalities are polymerase chain reaction, PCR, and confocal microscopic. Culture media for suspect fungal keratitis should include the same culture media used for general microbial keratitis workup. Sheep brood agar, saboral, dextrose agar, and triangulate broth should be included. So a definitive diagnosis for fungal keratitis is made if 1. The corneal scapules reveals fungal elements in smears. 2. Fungus grows in more than one medium in the absence of fungus in smears. 3. Fungus grows on a single medium in the presence of fungus in smears. And 4. When confluent growth of fungus appears in a colored site on a single solid medium. Next. To differential diagnostic as a result in indolent progression and failure to respond to antibacterial medication. Fungal keratitis often is misdiagnosed as septic or amoebic disease. Fungal infection following LASIK must be differentiated from the sterile interface infiltration or post-LASIK and diffuse lamellar keratitis, and from infection caused by bacterial species. In the management, consists of medical therapy and surgical interventions in case, which are not responsive to medical therapy. The efficacy of currently available antifungal agents is limited, as a relatively high medical treatment failure rate exists. The agents most commonly used for fungal keratitis include the polyenes and azoles. In the polyene medications, fotericin B, natimicin, and nystatin bind to fungal cell wall ergosterol and disrupt the cell. The polyenes are effective against for both filamentous and just forms. The periodontal in cornea may enhance penetration to topical medications, although it is unclear that the periodon results in better outcomes. One of the diagnostic has been made. Fungal keratitis should be treated with frequent applied topical antifungal medications. Since fungal keratitis responds slowly over a period of weeks, clinical signs of improvement should be noted. We include the following. Dissemination of pain, decrease in size of infiltrate, disappearance of satellite lesions, rounding of the factory margins in the ulcer and hyperplastic messes of fibrous shreds. The course of treatment in typical protein antifungal treatment is usually maintained over 12 weeks with a strict vigilance as medicines are tapered. Next. The intracameral amphotericin B may be a useful modality in the treatment of severe keratomycosis that not responding to topical natamycin. It ensures adequate drug delivery into the anterior chamber that may be especially used to avoid surgical interventions in the acute stage of the disease. Next. We have an article. It's called the mycotic ulcer treatment trial that was a randomized controlled trial that found that fungal ulcers randomized to natamycin had better vision at 3 months compared with those randomized to voriconazole as a result, driven largely from the efficacy of natamycin among fusarium ulcers. And in the second article, called effect of oral voriconazole fungal keratitis in the mycotic ulcer treatment trial 2. In this, talk about fungal ulcers with treated with topical therapy and randomized to oral voriconazole of placebo. After 3 months, the rate of perforation or therapeutic keratoplastia was not significantly different between the voriconazole and placebo groups. In fungal keratitis fails to respond to medical therapy, surgical intervention should be considered because of the propensity for fungal elements to embed debris, and in some cases, penetrate the cement membrane. Advanced cause required penetrating keratoplastia to ensure complete removal of the invaded fungus. In general, penetrating keratoplastia should be performed sooner rather than later to maximize the probability of a graft margin free of infection and to minimize the risk of endophthalmitis or infections scleritis. As generous or clear margin as possible should be included in the excited cornea. Thanks.
Thank you, Dr. Hoya. Now, before presenting the case, I have some points I want to stand out. About the stromal infiltrate, we need to know that the corneal epithelium will stay intact and it have a inflammatory response very limited. These two factors form a natural barrier to the penetration of fungal agents. On the other hand, we have the antifungal agents, of which we have a few options to choose. They are from hydrophilic nature. Let's remember that the epithelium cells are hydrophobic. And of course, the administration is conditioned by the time of diagnosis. These factors predispose therapeutic, the use of therapeutic penetrating keratoplasty. So the case is this. This is a 20-year-old woman referred to the Bascom Palmer Eye Institute for evaluation for a mid-stromal corneal infiltrate in her left eye, and a user of soft contact lens, and she used prednisolone to treat the red eye during the last year. This fact maybe sounds familiar to us all here in Latin America. Her best visual acuity, 20/20 in the right eye and 20/30 in the affected eye. Under the slit lab evaluation, we can appreciate a moderate conjunctival injection, two fluffy appearing mid-stromal infiltrates without overlying epithelial defects, and also a mild anterior chamber reaction was reported. Here in the image, we can see the findings of the slit lab. The patient arrived to the institute with oral acyclovir, topical trifluridine, and moxifloxacin for the last 2 weeks, with worsening irritation, light sensitivity, and blurred vision. I must say that this treatment wasn't given at the Bascom Palmer, was given by the first attendant. Now, the first approach, in first instance, fortified topical antibiotics were applied after corneal stains and cultures performed. They appeared to be negative for bacteria, fungi, parasites, and viruses. Also, confocal microscopy imaging at several time points during the treatment course did not show fungal EPI. As we can see, a prima facie, it wasn't very evident, the fungal infection. After a 10-day course of the fortified topical antibiotics, lack of response and high clinical suspicion for fungal keratitis led the team to a second approach, the use of topical natamycin every hour and oral voriconazole 200 milligrams twice a day, with corneal epithelial debridement performed every 2 days so as to improve the penetration of the topical antifungal. Here we can see that 4 weeks later, the infiltrate appeared larger and deeper, while the vision remained at 20/30. So the team decided to take another alternative. The use of serial intrastromal voriconazole, 100 micrograms injections for 10 days. But this treatment failed to prevent the infiltrate from further enlarging in size and penetrating deeper in the cornea stroma. The anterior chamber cultures were made, but still negative. So then our team used the serial intracameral voriconazole injections for an additional week and a half with the same results. Again, the treatment wasn't enough for preventing the enlargement of the stromal affection. The patient now presents hypopion and even a deeper infiltrate. This time, the vision declined to 20/40. We can see here in the lower part of the image our present hypopion. At this point, this must be the image that we will have seen in our heads, but our team did not give up and decided to call the chivalry of the 21st century, the OCT, anterior chamber OCT. Byzantine size doubling with axial resolution of 18 micrometers, range image acquisition of 10 millimeters per 3 millimeters, 512 scans per line showed, as we can see in the image, especially in the white arrow, an endothelial plaque. Now, the management options include a therapeutic penetrating keratoplasty or endothelial biopsy in order to identify the causative organism. After an extensive discussion with the patient and her family about the risk and benefits of each approach, the decision was made to proceed with endothelial biopsy in the operating room. After a 2-day holiday antibiotic period, the plaque was removed with a therapy scraper in a single piece, and the resultant endothelial defect in the area was approximately 3 per 3.5 millimeters in size. Also, cohesive viscoelastic was applied to limit the risk of seeding and keep the anterior chamber stable. Anterior chamber wash was performed and intracameral voriconazole was injected. Finally, the intrastromal and intracameral voriconazole injections were applied twice a week for the first post-operative month. It's worth to mention that anterior chamber cultures were again negative, yet histopathology with Gomori methaniman silver were positive with these fungal elements that are showed with the black arrows. Following its removal in the intermediate postoperative period, focal corneal edema was present at the site of the biopsy, which resolved over the next 4 weeks and yield to a paracentral scar in the patient. But the visual acuity still in a 20/20 in both eyes. So some highlights of this case. First, the value of the anterior segment OCT in the pinpointing of the location of a deep stromal infiltrate. As an infection penetrates deeper in the cornea stroma, its exact location is difficult to discern on clinical slit lab examinations. In the case, anterior segment OCT imaging clearly showed that the infectious needles had penetrated the cement membrane and had performed an endothelial plaque. The importance of histopathology for diagnosis of culture-negative corneal infections, and finally, the potential value of surgical debulking of a fungal endothelial plaque. Some conclusions about this case. First, the anterior segment OCT can aid in defining the exact location of a deep corneal infection. And it can reveal the presence of an endothelial plaque that may not be visible on the slit lab examination. Second, the endothelial biopsy can be performed both for diagnostic and treatment purposes in order to debug infections, needles, and guide subsequent management. Third, the removed specimen should be submitted always, both for culture and histopathology, because, as you can see, cultures may be negative in these cases. For intracameral antifungal or antibiotic injections at the end of the procedure and during the follow-up, in order to avoid the seeding of anterior segment and the development of endophthalmitis. And of course, putting an eye in the future, further studies are needed to assess whether the benefits of such biopsies for retrocorneal fungal injections outweigh the risks. And please remember that a negative culture doesn't mean being free from hidden microorganisms. Now, I would like to ask Dr. Sotiria for some comments about her experience in this case, and all you, my dear audience, for your contributions and questions, please.
So thank you for having me here today. That was an excellent presentation from both of you. Congratulations. So let me share a few thoughts about this case and in general about fungal keratitis, which is one of the hardest infections both to diagnose and to treat. First, the confocal microscopy. We did do confocal microscopy and we did not see fungal hyphae. In Miami, the confocal is done by a technician. In Athens, where I mostly practice now, I have a confocal and I operate it myself. It's very dependent on who uses the machine. So the more you do yourself, the better images you're going to get, and the better you're going to get at identifying abnormal things in the cornea. So maybe we did not find the hyphae because we were not looking at the right place. It's very difficult when you do confocal to image off center because the cornea has a curvature. So the patient has to turn his or her head. So I'm not sure that the actual images we got at that time were over the lesion because the adjacent cornea would be normal. So that's one thing. So if you have access to confocal, or if you ever do, it's very important to know how to use it. And the more you do it yourself, the better you become at identifying fungi, amoeba, or microsporidia, or other things you can. But you have to do it yourself. That's one advice on that. Second, when the patient presented, as Manolo pointed out, she had an intact epithelium, which I see very commonly with fungal ulcers, especially the types that penetrate deep in the cornea. In this case, most likely it was a fusarium fungus because it never grew from her eye, but we did have a culture from her contact lens case that had a mixed infection, but among those organisms was fusarium. And fusarium can penetrate deep and it protects itself by having the corneal epithelium seal on top of it. So when you take a culture, and when you see an infiltrate in the cornea and it has an intact epithelium and you want to take a culture, go ahead and scrape it and try to dig, especially if it's in the anterior stroma. And when we prescribed to the patient voriconazole topically anatomized, and she was coming to clinic 3 times a week, and we would scrape the epithelium so that she would have better penetration of the drops. Because once the epithelium forms, which in a young woman would form within 2 days, that's it, that's your chance. So she would come 3 times a week for scraping so that the drops would penetrate better. So despite those efforts, she progressed. We could see the infiltrate going deeper, and that's when we decided to do intrastromal injections. At the same time, of course, we were contemplating whether this is really a fungus, what we thought about clinically, but whether it was like something else that we were missing, like a typical mycobacterium or something else. You know, when your treatment is not doing what you expect, you always have to question whether you're treating the right thing. But we thought that from all the options, we would continue with the antifungals and see how it goes. So we did do the intrastromal injections again 3 times a week. So it was not a single injection. It was Monday, Wednesday, Friday, and it was done at the slit lamp. It's more comfortable if you have access to an operating room or a small procedure room, but at the slit lamp, you can see the depth. So if the patient can tolerate it with a speculum at the slit lamp, it may be a little harder for you to do the injection, but looking through the slit lamp, you can see where exactly you're injecting and at what depth you're injecting. So after the intrastromal and the intracameral injections, because we could see clinically that the infiltrate was going deeper, we were actually thinking to do a therapeutic penetrating keratoplasty, although the patient had very good vision. She had 20/30, 20/40 was the least she got. And at that time, we did an OCT and saw the endothelial plaque. I have to say that in other fungal infections, the endothelial plaque may not be fungus, it may be an inflammatory plaque. In this case, it was fungus. You don't know when you see a plaque, especially from a fungal infection, if it's inflammatory or if it shows penetration of descendants. It's very hard to know. So we took a risk. The family agreed that there was risk of seeding during the procedure in order to scrape the plaque. I'll come back to this. I just wanted to say that the OCT, since this ulcer, I have started to use the OCT a lot in my practice, especially not only the line, but also the corneal thickness map that some OCTs can give you. Most of the modern anterior segment OCTs can give you a whole corneal thickness map. So in any infection, and especially in fungal infections, you see a lot of edema in the cornea. So even if clinically the infiltrate doesn't look a lot better, if you do serial OCTs every time the patient comes back, once the infiltrate starts responding, you'll see that the thickness gets thinner. The OCT gets thinner, even if you cannot discern that difference in the slit lamp, because initially it will be only 50 microns of difference. But it gives you, a reassurance that something is responding since the edema is going away. So since that case, I've been using the OCT a lot to monitor patients that have ulcers of any kind, especially fungal, because they tend to have a lot more edema in the surrounding cornea than other, let's say, bacterial ulcers. Now, in the OR, in order to prevent seeding, we injected viscoelastic. So it was not the whole chamber that had viscoelastic, it was particularly under the plaque, under the infiltrate, so that we would prevent seeding to the whole anterior chamber. You could feel the chamber too. I don't think there's any harm in that, but it will be harder to remove it. And this way, then that's how we removed it, and we avoided seeding. But also, we gave intracameral antifungals at the end, also antibiotics, the standard antibiotics, and we continued for about 3 or 4 weeks with intracameral and intrastromal in the area antifungals in your follow-up visits. So this way, I think we were successful in preventing seeding and endophthalmitis. And I think someone has a question, so I'm happy to take it.
Yes, first of all, Doctora Analia Pérez Balbuena from the Asociación para Evitar la Ceguera asked, at this moment in Mexico, we do not have natamycin. What medicine would you recommend?
Yeah, it's very unfortunate. It's the same in Greece. So the only option is voriconazole, unless you know or you think it's candida. If you have a positive candida culture, then amphotericin usually works better and it's cheaper. But if you don't and you just know it's fungus, then you have to use voriconazole. I don't think that fluconazole is good enough, because if you use fluconazole, yes, it may work for some fungi, but if it doesn't work, you don't know whether you're under treating or the fungus is resistant to the medication, which is expensive, of course.
Thank you, Dr. Tirian. Now, Dr. Alberto Rojas.
Hi. Well, first of all, I would like to thank you, Dr. Sotheria. It's a pleasure to join us in this session. And second, I would like to congratulate Dr. Rodriguez and Dr. Hoya. And I have a question for you. Dr. Sotheria, in your experience, you treat keratitis differently in the United States compared to Greece, taking into account that ophthalmic antifungals are not always available. And do you have any experience manually preparing anatomizing?
Yeah, so no experience in manually preparing natamycin. We do have a very good compounding pharmacy in Athens, and they do compound voriconazole, but natamycin is not available. And no, I don't treat it differently. I treat it exactly the same way. So if someone, I have my algorithm, which is basically the US-based algorithm. Whenever someone comes with a corneal ulcer, if they're on antibiotics, they get a holiday for at least 24 hours. Nothing catastrophic is going to happen to the cornea if someone stays without antibiotics for 24 hours, but you will get a better culture. And then I generally start with broad spectrum fortified antibiotics, so vancomycin amikacin or vancomycin ceftazidime or vancomycin tobramycin, something for good gram-positive and gram-negative coverage. Unless I have, because I do confocal in all my ulcers in Greece, unless I see acanthamoeba cysts on the confocal and I see hyphae, which means I don't need a culture, I can directly treat for that organism. But that's not the common scenario, that's the exception. And then if someone does not respond to the fortifieds, which you have to wait, after 2 days of Q1 hours, the patient should feel at least a little better, even though what you see at the slit lamp is probably the same, but the symptoms should be a little better if someone is responding. But if someone is not responding, then after about, I would say 7 to 10 days, depending on how big the infiltrate is, I will have to either take a corneal biopsy or add a topical antifungal if I feel that there is a risk of infection. In general, I don't like to start an antifungal unless I have a reasonable suspicion or a positive culture.
Thank you.
But that's the same in the US. It's the same algorithm that we use in the US. We don't rely so much on the confocal because, like I told you, it's a technician that does it. I think now in Miami, more and more physicians are trying to do it in their busy clinics, and I think that would be more helpful. Yes.
Thank you. We have 3 more questions. First, Dr. Rodrigo Mateos.
Hello, good morning, Dr. Sotiria, and to everyone. It was a great presentation. But I have a question. What do you think about the role of the cross-linking in these cases?
Okay, so there have been several studies that show that for bacterial, at least ulcers, cross-linking can help, and the UV light can actually kill the organisms. For acanthamoeba or fungi, it doesn't seem to help, at least in the studies. I don't generally recommend it to my patients. There are some protocols from Switzerland, classic, I'm talking about the classic cross-linking with UV light and riboflavin. Rose Bengal PDT that we do use in Miami, that is a customary cross-linking, and we have the machine there. That works well in fungal keratitis, even in bad fungi, and it works in some cases of acanthamoeba. But we don't have, no one has access to that unless you are in Miami. Or there's also a machine that Bascom Palmer has donated to Aravind and LV Prasad in India. So that's the only places that have this machine. Classic cross-linking with a classic Dresden protocol does not seem to work for fungal infections or for acanthamoeba. There are other protocols that Farhad Hafezi from Switzerland claims that they would work, and they use higher fluence, so more energy, more time, deeper penetration, for example. I have no experience with those protocols, and I haven't used them in Greece or in Miami.
Thank you.
Now, Dr. Liepes asked if, what do you think about argon laser in keratitis?
In fungal keratitis?
Yeah.
I have never used it, to be honest with you. I have no experience with it.
Okay. And Dr. Lisette Bejar asked, here in Guadalajara, we do not have ophthalmic voriconazole, only IV ampules. How do you recommend to prepare it, and what dosage do you use?
Yeah, so Exactly. So you have to speak to a pharmacist so that they can compound it. And if you Google topical voriconazole, I think it's 1% that we do typically use. And the pharmacist can also find instructions online about exactly how to prepare it based on the ampules. So that's how they do it in Miami. That's how they do it in Greece. It's not available as ophthalmic, so you have to take the IV medication and dilute it down and sterile filter it and then use it as a drop. So a pharmacist should be able to do that. The same way they make vancomycin or amikacin or all these drops. Like you just need a compounding pharmacy. There must be one available, no? I mean, there's one in Athens, at least one, but there is one.
Our experience here is we sometimes need to prepare the drop, yeah, in some places of the country. I don't know if there is another question.
But there are protocols online. I mean, you have to look at what is the concentrations of the ampules you have, because I've had to prepare it myself in the operating room here for an intravitreal injection. And you have to look at the concentration of the ampules, look at the final concentration that you need on the drops. I think it's 1%, but I may be wrong on that. And then just make sure you do the correct dilutions. So you have to be comfortable with dilutions, basically, and then you can prepare it.
Thank you. I don't know if there's another question before ending the session.
I have a question for Dr. Azotea. In this case, well, we saw there was no positive response to the topical antifungal therapy and intracameral before going to the OCT as a diagnostic tool. So for further cases, how long would you say we should wait before using the OCT as as a diagnostic tool to help us treat this entity?
Like I said, since this case, I use it very often. And a lot of my ulcers. And I also, when you have a small infiltrate, for me, I mean, that's empiric, that's what I do. But if you have a small infiltrate, it looks at maybe fungal, like it has this feathery borders, the patient has a risk factor, like was working with plants or was using topical steroids in their eye. And you see a lot of edema on the OCT in the rest of the cornea. To me, that it has turned out to be fungal. So, and then once you start treating, you see that the edema decreases, and that helps a lot, to guide your treatment. So I do use the OCT a lot now since that case. I was not using it before that case, but after this case, I started using it a lot. So you can use it early on too, because you can see where the infiltrate is, if it's moving deeper. Especially if you have different people examining the same patient, at least you have an image of how deep the infiltrate is. And if it is really moving deeper, or maybe it's not, or maybe it's stabilized. And also, if you see that the general corneal edema, if you do an OCT thickness map, gets better, that tells you that your treatment is doing something.
Thank you.
Of course.
Okay, thank you very much for all your questions. I think there's no another question or comment. Well, I think we can end this session. Dr. Sotiria, Evharistopoli again for all your for attendance, and thank you for all our lovely audience for your questions and all your comments. I hope we can work again in the future.
Of course, thank you for having me. Great job on the presentations.
Thank you. Have a nice evening and a good day to everyone here in Mexico and Guatemala.
Thank you.
Thank you.
Thank you.